All right, if you're gearing up for the BCOP exam, you know bladder cancer is a topic you just can't skip. So in this explainer, we're going to do a super high-yield, rapid-fire review, hitting all the key clinical pearls that are going to make a real difference. Okay, let's get right into it. So let's kick things off with a pretty staggering number. What in the world does this represent? Well, this is the percentage of all bladder cancers that can be traced directly back to cigarette smoking. It is by far the single biggest risk factor and something you absolutely have to ask about in a patient's history. Just lock that number in your head, 50 to 60%. So here's our game plan for today. We're going to start with the fundamentals, the absolute basics you need for diagnosis and staging. Then we'll walk through the whole clinical journey, from non-muscle invasive to muscle invasive and all the way to metastatic disease, covering the standard of care for each one. And then we'll wrap it all up with the most critical takeaways for your exam. All right, Section 1, bladder cancer fundamentals. You gotta get this stuff right because honestly, every single treatment decision we make flows from here. Okay, we've already hammered home that smoking is number one, but for the exam, you've got to know the other players too. Things like occupational exposures, especially to aromatic amines in industries like painting or textiles, can account for up to 20% of cases. Chronic inflammation is another big one. Think long-term indwelling catheters. And of course, a key one for us pharmacists, prior exposure to cyclophosphamide. Histology-wise, in the US, you're almost always talking about urothelial. Now, this slide right here, this is arguably the single most important distinction you can make in bladder cancer. Is it non-muscle invasive or has it invaded the muscle? These are two completely different diseases. About 70 to 80% of patients show up with NMIBC. Here, the big enemy is recurrence, the cancer coming back. For the other 20-30% with MIBC, the whole game changes. The goal now is to stop it from spreading, and the treatments get way, way more aggressive. Okay, so let's move on to Section 2 and see how we manage that first, larger group of patients with non-muscle invasive disease. The key word you need to know here is intravesical, meaning the therapy goes directly into the bladder. So the management pathway for these folks is a pretty clear three-step process. First up, the urologist does a TURBT, a transurethral resection. They go in, scrape out the visible tumor, and this is critical, get tissue for staging. Then, based on that pathology report, we risk stratify the patient. And that risk level is what tells us exactly what kind of intravesical therapy they're going to need. So how do we actually do this risk stratification? Well, it all comes down to the tumor's features. A small, single, low-grade TA tumor, that's low risk. But the second you see T1 disease, meaning it's invading the lamina propria, or if you see any carcinoma in situ, you'll see it abbreviated as TIS, that patient is automatically bumped into the high-risk category. This decision point is absolutely key for what comes next. And for those intermediate and high-risk patients, the go-to agent is intravesical BCG. Now, this is so cool. It's not chemo, it's immunotherapy. We're actually instilling a weakened strain of bacteria, the same one used for the tuberculosis vaccine, right into the bladder. It kicks off this massive local immune response that then attacks and kills the cancer cells. It's a pretty wild mechanism of action. Okay, for the BCOP exam, you absolutely have to know these pearls. First, BCG is hands down better than intravesical chemo for carcinoma in situ. The schedule is a 6-week induction, which is then often followed by maintenance therapy for 1 to 3 years. From our pharmacy perspective, managing toxicities is huge. For local stuff like burning and frequency, think phenazupyridine. For systemic flu-like symptoms, simple acetaminophen or NSAIDs usually do the trick. And the biggest red flag, you have to hold the dose if there's any trauma to the bladder, like from a tough catheterization. Okay, big pivot now. We're shifting gears completely to muscle-invasive disease. The whole approach changes from local to systemic, and believe me, the intensity gets cranked way up. This right here is a must-know point. The undisputed, Category 1 gold standard of care for muscle-invasive bladder cancer is neoadjuvant, that means before surgery, cisplatin-based chemo, which is then followed by a radical cystectomy. The whole idea is to shrink the tumor and kill off any stray cancer cells before you even get to the operating room. So, which cisplatin regimens are we using? Well, you've got two main players. Gemcitabine plus cisplatin is an option, for sure, but the preferred regimen, the one with the best data, is dose-dense MVAC. It's more intense, given every 2 weeks with growth factor support. Now, here's the key pharmacy pearl for DDMVAC you gotta remember. The protocol actually allows for splitting the cisplatin dose for patients with a creatinine clearance down to 50. This is huge because it lets us treat a lot more patients who otherwise wouldn't qualify. Okay, on to our last treatment section, advanced or metastatic disease. At this point, sadly, the cancer has spread beyond the bladder, so our goals have to shift towards extending life and, just as importantly, maintaining quality of life. So in the metastatic setting, everything, and I mean everything, comes down to one single question. Can this patient get cisplatin? This one factor determines the entire first-line treatment plan. It is the absolute first branch in the decision tree. And this slide lays out those two paths beautifully. If the patient is cisplatin eligible, we use the same regimens we just talked about, DDM-VAC or GemCis. But, and this is a huge but, what comes next is critical. Avelumab maintenance therapy is a Category 1 recommendation for anyone who doesn't progress. Now, if they're cisplatin ineligible, the new standard is a powerful combo of an antibody drug conjugate and fortumab vedotin plus pembrolizumab. Gemcitabine plus carboplatin is another option there. This whole idea of maintenance therapy was a total game changer, and it's a huge point for the exam. The Javelin Bladder 100 trial is the reason avelumab is now the standard of care. It took patients who had finished their platinum chemo and were stable, and it proved that just continuing with avelumab made them live significantly longer. Just look at the data. The numbers here really tell the whole story. Patients who got avelumab maintenance lived a median of 21.4 months, compared to just 14.3 months for those who got supportive care alone. That's a 7-month improvement in median overall survival. That hazard ratio of 0.69 means a 31% reduction in the risk of death. I mean, that is absolutely practice-changing stuff. So what happens when patients do eventually progress? Well, in the second-line setting and beyond, the most important drug you need to know is enfortumab vedotin. It has a crystal-clear Category 1 recommendation for patients who have already been through both platinum chemotherapy and a checkpoint inhibitor. Okay, we have covered a ton of ground, so let's boil it all down into the most critical, high-yield points that you absolutely need for your exam. This is the rapid-fire review. First, let's just ground ourselves in the prognosis. The stage at diagnosis makes a world of difference. For non-muscle invasive disease, 5-year survival is pretty good, over 70%. But as soon as it invades the muscle, look at that drop, down to 30–40%. And for metastatic disease, it's a grim 5%. This really just drives home why preventing progression is so incredibly important. So let's make this simple. If you take nothing else away, remember this. For NMIBC, think intravesical. Know your BCG and its side effects. For MIBC, the answer is neoadjuvant cisplatin, then surgery. For metastatic disease, your first question is always about cisplatin eligibility, and you cannot forget avelumab maintenance. And finally, for relapse disease, you have to know the role of enfortumab vedotin. You nail these 4 points, and you've got the core of bladder cancer therapy down cold. And we'll end with a look to the future. You know, with these incredibly powerful new drugs like enfortumab vedotin and combination immunotherapy moving up into the first-line setting, you have to wonder, are we on the verge of a totally new paradigm? Could we see a day where traditional chemotherapy is no longer the backbone of treatment for advanced bladder cancer? It's a really exciting question that's going to define the next decade of research.